Good morning. Emeritus Sonika sir, Provici Kapoor sir, Saxena sir, and Andy Soni sir. Today's postgraduate combined round is 8th in that series and is on the Pandora's box of our body. Department's residents will be discussing their perspective on acute abdomen. The moderator for today's PGCR is Dr. Shireesh Gupta from the Department of General Medicine. Now I'd like to invite Dr. Sawan from General Medicine to start the PGCR.
Good morning, respected faculty members, teachers, and my dear colleagues. I will be discussing Introduction to Acute Abdomen. Definition: an acute attack of abdominal pain that may occur suddenly or gradually over a period of several hours. Patient presents symptom complex that possibly threatens life, demands an immediate or urgent diagnosis for early treatment. Mostly due to an inflammation, infection, hemorrhage, ischemia, obstruction, and perforation. Various character of pain. Colchi pain is due to spasm of a smooth muscle in a hollow viscous organ. Pain is sharp, intermittent, gripping-like pain which comes suddenly and disappears suddenly, like in biliary colic, renal and urinary colic, and intestinal colic. In cholecystitis, the lacking pain present with persistent and less intense pain in visual organ. Sharp pain, sudden and intense pain that similar to be stabbed by a sharp object like torsion of testes. Burning pain feels like a heat or burning sensation caused by a contact with a hot object like in peptic ulcer and reflux esophagitis. Stabbing pain is sudden, severe, sharp and localized, often felt with movement or pressure like in acute perforated peptic ulcer. Shooting pain is sudden, intense pain that radiates along a nerve pathway like in radicular pain. Shifting pain initially felt around the umbilicus, then it radiates to the right iliac fossa due to parietal peritonitis like in acute appendicitis. In peptic perforation, there will be a radiating pain. Pain is first complained at the region of the affected organ and it radiates to the another region. Referred pain. Pain is felt at some other region having the same segmental innervation as the site of lesion like in acute cholecystitis. Cramping pain is due to a muscle contraction or spasm like in dysmenorrhea. Thrombing pain is steady, rhythmic pulsing pain often associated with vascular issues or inflammation like in pyogenic abscess. Scalding pain is a type of burning sensation which is felt during maturation like in cystitis and acute pyelonephritis. These are the most common causes of acute abdomen, which are arbitrarily divided into surgical causes, gynecological causes, medical causes, and pediatric causes. Examination of abdomen. Patient should lie supine with legs extended. Abdomen exposed from nipple to mid-thigh. Abdomen divided into 9 regions by 2 vertical line and 2 horizontal line, which is transpyloric and transtubercular. Vertical line starts from the mid-clavicle line to mid-inguinal point. Transpyloric line joining from both the sides of 9 tip of the costal cartilage. And transtubercular line joining from both the sides of 2 inches behind from the anterior iliac superior spine. On inspection, we look for skin over abdomen. We look for any hyperpigmentation or hypopigmentation or discoloration over abdomen or redness or any bruising over the abdomen. Then we look for contour of abdomen. Flat and scaphoid abdomen is normal and distended abdomen is seen in 5 P's, which is flat, flatus, feces, fetus and fluid. Then we look for quadrant of abdomen moved equally with respiration. The abdominal moving is absent in diffuse peritonitis or in intestinal obstruction. Peristaltic movement is seen in abdomen is left to right or right to left in intestinal obstruction. Look for any pulsating swelling in aortic aneurysm patient. and inspect all hernial orifices like umbilical hernia, incisional hernia, inguinal hernia, and femoral hernia. On palpation, we examine hyperesthesia. Like in acute appendicitis, there will be hyperesthesia in the Serines triangle, which is triangle formed by umbilicus, pubic symphysis, and anterior superior iliac spine. Then we examine for tenderness. Then muscular guarding. Muscular guarding is an voluntary contraction of the abdominal muscle by the patient due to fear of pain. Muscular rigidity is a reflex of the abdominal involuntary contraction of abdominal muscles due to a diffuse peritoneal inflammation. The question to the audience: what is the rebound tenderness? To elicit the rebound tenderness, clinician palpates and maintain pressure over an area of tenderness. Then patient gets relief of pain and withdraws hands abruptly. Patient winces in pain upon withdrawal of hand. We examine any palpable.
Whenever he is asking for rebound tenderness, it has to be peripheral peritonitis. Unless the peripheral peritonitis is not there, there cannot be rebound tenderness. Once you press deeply and then release, and there is peripheral peritoneal irritation, it leads to the pain. Rebound tenderness. Am I right? There are two peritoneum, distal peritoneum and parietal peritoneum. So the inflammation of the parietal peritoneum leads to the rebound tenderness. Yes.
Then we examine for any palpable lump palpable in the abdomen, and we examine palpation of all hernial sites. On percussion, we perform shifting dullness. Shifting dullness is performed by percussion. Start from the midline and resonant note is heard, and move laterally towards the anterior superior iliac spine until the note becomes dull. Then ask the patient to lean laterally, and examined fingers should be on the same position and wait for 30 seconds. On percussion, resonant note is heard and the test is positive. Flute thrill performed by patient head should be on midline of the abdomen, then taps on the flank while feeling on the other side of flank for the tap, and test is positive. The image showing obliteration of liver dullness. Percussion start from second intercostal space in right midclavicular line, and resonant note will be heard. And moving downwards on the fifth intercostal space, note will be changed from resonant to dull note. If the note still persists, then gas under diaphragm for perforation can be suspected.
You have to start off, you have to know why you are percussing the liver. And that unless you have that in mind, you will not be able to do a good percussion. So let's imagine that there's a patient here and you have a margin of the liver over here. You will start off from which end? Will you start from below upwards, or will you go from above downwards? Above downwards. That is the primary thing. And very often we see our residents and even students doing it is, this is the patient lying here, this is the patient this way. They'll start off this way and go up. No, it has to be from the, and from which intercostal space? Not the faculty, please. So it will have to be from the second intercostal space. Again, one of the major mistakes that you make is that you start percussing here to liver hota, yahan se cut kar diya, and that's where you start missing the things. You are not looking at something which is routine, you are looking for something which has to be looked at even if it's rare. So you start off with the second space and then you go down and continue till the percussion note is dull. And then you can come from below upwards to be able to identify the margin. That is the reason why we do a percussion of the liver, and we have to look for two things. Is the liver enlarged or is the liver shifted down? Again, they are the two things that come up from the percussion of the liver. Tenderness and all those things will come in, but the basics are that you have to start from the second space, go downwards, and then go from below upwards in the right iliac fossa upwards. It's again not the fossa, suprapubic region, you go upwards. And you have to distinguish between the enlargement and the shifting of the liver downwards. These are the two important things that you have to see.
On auscultation, we hear bowel sounds. There are hyperactive bowel sounds, hypoactive bowel sounds, and silent abdomen. Hyperactive bowel sounds are seen in intestinal obstruction, and hypoactive bowel sounds are present in paralytic ileus or electrolyte imbalance, and silent abdomen in perforation peritonitis. No examination of acute abdomen is incomplete until the examination of rectum. They are the most common surgical causes of acute abdomen, which are divided into 9 regions. Cholecystitis, cholelithiasis, and liver abscess are the causes of right hypochondrial region. Acute appendicitis is the cause of epigastric region. Splenic infarct and splenic abscess are the causes of left hypochondriac region. In both right lumbar and left lumbar, nephrolithiasis and acute pyelonephritis are the cause. Appendicitis is the cause in the right iliac fossa. Strangulated hernia and torsion of testis and some gynecological causes are present at both right iliac and left iliac region. Cystitis is the cause in hypogastric region, and colonic diverticulitis and sigmoid volvulus are the cause in the left iliac region. Here,
ये जो 9 क्वाड्रेंट्स हैं ये तो खैर याद रहनी चाहिए, तो 9 रीजन्स, पर for better clinical decisions you make it quadrant. Like I said, vertical from the sternum to the and horizontal line on the umbilical. And in the 4 quadrants, upper right, upper left, lower right, lower left. So you will come to know, because कई बार काफी नॉन स्पेसिफिक होता है, ठीक है, इस तरह से तो फिर आपको डायग्नोसिस एग्जैक्टली तो छोटे एरिया होते हैं जहाँ पे डायग्नोसिस करना, इसमें ये हो सकता है थोड़ा सा मुश्किल। Am I right? It is better to go first with the quadrant and then go to the regions.
You have this common causes in females, salpingo-nephritis, ruptured ectopic. That is very important for acute lower abdomen.
So it will be discussed in the gynecological parts. Yes, sir.
You are saying?
Yes, sir.
See, well, once continuing with what Dr. Kapoor has said, when we look at the causes of acute abdomen, as a surgeon you say you look at the surgical causes, and what happens is that you miss out causes of other specialties. So the causes of acute abdomen for everyone, whether he is a surgeon or a physician or a gynecologist, should include all things, whether it's porphyria, whether it's radiating pain. So थ्योरी में आंसर करने का ठीक है कि सर्जिकल कॉज ही होते हैं, गायनी ही होते हैं, बट जब आप acute abdomen पे प्रोसीड कर रहे हो, then as a surgeon or as a gynecologist you cannot exclude causes कि मेरे को तो ये कारण याद है. So that has to be kept all the time.
Other is whenever you are dealing or you are seeing a patient with acute abdomen, you have to remember acute chest also, acute myocardial infarction, acute events in the lung, pneumonia, and vascular causes. They can present as acute abdomen, but the cause is in the chest. So if you see a patient with acute abdomen who's middle age or elderly, and now of course post-COVID even young people, you have to keep at the back of your mind that it could be an unusual presentation of an acute myocardial infarction, especially the inferior wall MI.
Now the clinical features of the surgical causes of acute abdomen. Cholecystitis with cholelithiasis. The question to the audience is, what is Saint's triad? The Saint's triad is gallstone, hiatus hernia, and colonic diverticulitis. Patient present with pain in right hypochondrium and or epigastric region. The pain relates to the posteriorly on the right side between the at the inferior border of the scapula, and sometimes related to the tip of the right shoulder. Murphy's sign Murphy's sign positive. Murphy's sign is examiner standing behind the patient sitting position on palpation, finger hooked under the right costal margin, and ask the patient to take a deep breath. And patient catches his breath if gallbladder is inflamed and the test is positive. Boas sign is hyperesthesia between the 9th and 11th rib posteriorly on the right side. Cholelithiasis with cholangitis. Patient present with intermittent pain, intermittent jaundice, and intermittent fever, which is Charcot's triad. Patient may progress to the shock, which is hypotension, and altered mental sensorium, which is Reynolds pentad. There will be a tenderness in epigastrian region and hypochondrial region. Renal and ureteric stones. Patient present with severe abdominal flank pain, with nausea and vomiting, with renal angle tenderness. Renal angle is angle between the erector spinae and the lower border of the 12th rib. And patient sometimes may present with hematuria also. Pyelonephritis, patient present with loin pain with fever associated with burning maturation and renal angle tenderness. Perforation peritonitis, patient present with generalized pain abdomen followed by abdominal distension and vomiting with the signs of peritonitis. That could be tenderness, rebound tenderness, muscular guarding, or board-like rigidity. Mesenteric ischemia, patient presents severe postprandial pain and patient avoids taking food and substantially there will be a weight loss, followed by vomiting and abdominal distension. As shown in the image, as in the intraoperative image, there is the gangrenous small bowel is there. Acute intestinal obstruction, the first complaint of the patient is constipation or obstipation, followed by pain abdomen with abdominal distension. Earliest feature of vomiting is present in small bowel obstruction and the late feature will be in the large bowel obstruction. As the image showing, there is dilated bowel loop with the cause of intestinal obstruction. Appendicitis, there is a pain in lower abdomen with vomiting and fever, which is known as Murphy's triad. On examination, there will be tenderness and rebound tenderness on McBurney's point. McBurney's point is medial 2/3 and lateral 1/3 on the imaginary line from umbilicus to anterior superior iliac spine. Strangular inguinal hernia, patient present with pain in inguinal region, with tense swelling in inguinal region, with severe tenderness, with skin changes over swelling, irreducible and without any expansile impulse on cuffing. What is the pathognomic feature of testicular torsion? The patient of testicular torsion present with pain in inguinal scrotal region with Prehn's sign positive. Prehn's sign is on lifting or elevation of scrotum, there will be increase in intensity of pain and the test is positive. The pathognomic feature of testicular torsion is loss of cremaster reflex. Diverticulitis, patient present with pain in left lower quadrant with abdominal distension and tenderness in left iliac region. Simmered volvulus, patient present with pain in left lower abdomen with abdominal distension followed by constipation or obstipation with tenderness in left iliac region. Liver abscess and acute pancreatitis will be discussed by the Dr. Kushagra, and I will like to call Dr. Kushagra Jaiswal to discuss the medical cause of acute abdomen.
Moving forward with the medical causes of acute abdomen. Acute pancreatitis. It is a sudden inflammation of pancreas. Patient usually presents with epigastric pain radiating to back, which relieves on bending forward, as we can see in the image, along with nausea, vomiting, and fever. Liver abscess. It is a most common visceral abscess, and it is polymicrobial in nature. Patient present with pain in the right upper quadrant, along with tenderness, fever with chills, nausea, and vomiting. The image shows drainage bag with anchovy sauce appearance, which is characteristic of amoebic liver abscess. Peptic ulcer disease. Patient usually present with epigastric pain, loss of appetite, weight loss, dyspepsia, and is the most common cause of upper GI bleeding. Gastroesophageal reflux disease. It is defined as backward flow of gastric contents into the esophagus. Patient present with epigastric pain along with retrosternal burning sensation, which is most common, regurgitation, dysphagia, and some extra esophageal symptoms like chronic cough, laryngitis, dental caries. The image showing endoscopic view of gastric ulcers. I would like to ask the audience, this is an image of a characteristic rash present with pain in abdomen along with fever. Can anybody spot the diagnosis? It is a diagnosis of typhoid fever. Patient usually present with step ladder pyrexia, right upper quadrant pain, row spots as we have seen in the image earlier, along with abdominal distension and relative bradycardia. Spontaneous bacterial peritonitis. It is a severe complication of ascites characterized by spontaneous infection of ascitic fluid without an intra-abdominal source. Patient usually present with abdominal pain, tenderness, along with abdominal distension and altered mental status, decreased bowel sound. Splenic abscess. It is most commonly seen in immunocompromised patient. Patient usually present with pleuritic pain, left upper quadrant pain and fever. Addisonian crisis. It can be result from either destruction of both adrenal cortices or from a deficiency of ACTH. It is caused by stress and rapid withdrawal of steroids. Patient usually present with acute abdominal pain, hypotension, vomiting, hyperpigmentation. Hypercalcemia. Patient serum calcium of greater than 10.5 mg per dl is defined as hypercalcemia. Patient usually present with bone pains, recurrent abdominal pain, renal stones, fatigue being the most common symptoms in patients with hypercalcemia, nausea and vomiting, and confusion. Acute intermittent porphyria. It is an autosomal dominant condition resulting from half normal level of HMB synthase activity, which is involved in heme synthesis pathway. Patient usually present with abdominal pain and it is poorly localized, may be associated with cramping, ileus, abdominal distension, decreased bowel sound, and constipation. Tachycardia, insomnia, seizures, and mental symptoms such as anxiety can also be seen. Diabetic ketoacidosis. It results from absolute or relative insulin deficiency combined with counter-regulatory hormone excess. Patient present with acute abdominal pain, dehydration, vomiting, tachycardia, polyuria, and shortness of breath. The image shows the characteristic Kussmaul's respiration, which is a rapid, abnormal, rapid deep breathing at a constant pace associated with metabolic acidosis. Irritable bowel syndrome. It is a functional disorder. Patient present with recurrent abdominal pain at least 1 day per week in last 3 months, along with change in stool frequency and form. Crohn's disease. It is an inflammatory bowel disease. Patient usually presents with recurrent episodes of right lower quadrant pain, fever, weight loss, lymphadenopathy, and some extra intestinal manifestations like pyoderma gangrenosum, episcleritis, uveitis, ankylosing spondylitis. The image shows an endoscopic view of skip lesions which are characteristically seen in Crohn's disease. Now I would like to call Shipra Majumdar to carry forward the presentation. Thank you.
Good morning, everyone. Moving forward towards the common pediatric and neonatal causes of acute abdomen. The common neonatal causes of acute abdomen can be necrotizing enterocolitis, which is the most common GI emergency seen in neonatal ICU and is usually seen in very low birth weight and preterm infants. Most common site involved are the distal small intestine and proximal large intestine. Baby may present with a fulminant and rapidly progressive illness, which includes abdominal distension, erythema over the abdomen, and features of sepsis like lethargy, irritability, poor feeding, fever, respiratory symptoms, and poor perfusion may be present. A case of intestinal obstruction may present with recurrent episodes of excessive crying with bilious vomiting and abdominal distension. The common pediatric causes of acute abdomen are acute gastroenteritis, which may present with umbilical and paraumbilical region pain with vomiting and diarrhea. Urinary tract infections may present with dysuria, urgency and increased frequency, abdominal pain at the suprapubic region. A case of hepatitis may present with right hypochondrial pain, jaundice, high colored urine, and anorexia. Intussusception. Intussusception occurs when a portion of alimentary tract, that is the intussusceptum, gets telescoped into an adjacent segment, that is the intussuscipiens. The most common presentation is ileocecal and is seen between the age group of 5th month to 3 years of age. In typical cases, there is sudden onset severe paroxysmal colicky pain in a previously well child. The pain recurs at frequent intervals and is accompanied by straining efforts with legs and knee flexed and loud cries. A classical triad of pain, a palpable sausage-shaped mass, and bloody red currant jelly stools can be found. The slide here shows a case where there is purpural rash and the patient may present with acute abdomen. So it's a spot diagnosis for the audience. Yeah, it is HSP. It is inoxidable purpura. and henoch-Schönlein purpura is the most common vasculitis of childhood and is characterized by leukocytoclastic vasculitis and immunoglobulin A deposition in small vessels in skin, joints, alimentary tract, and kidneys. Most common age group is 3 to 10 years. The hallmark of HSP is a rash, which is a palpable purpura, starting as pink macules and gets developed into petechiae or raised purpura. The skin lesions are usually symmetric and occur in gravity-dependent areas, extensor aspect of upper limb, or pressure points. The musculoskeletal involvement, including arthritis and arthralgia, may be present. GI symptoms, including abdominal pain, diarrhea, and vomiting, is seen in 80% of the cases. And renal manifestations like hematuria or hypertension is seen in almost 30% of the cases. The peripheral blood smear is usually suggestive of presence of schistocytes, that is the fragmented red blood cells. Other common causes of acute abdomen like acute pancreatitis, acute appendicitis, pyelonephritis, and torsion testes have already been covered by the medicine and surgery department. Now we will describe how to approach a patient with pain abdomen if they belong to the age group from neonate to less than 2 years of age. As in this age group, we don't have much history, so we rely on the telltale signs, the examination findings, and investigation. If a patient presents with the telltale sign of excessive crying for less than 24 hours with the symptom of abdominal distension and tenderness, we go for the history and the findings on general physical examination and systemic examination, and then we carry out the relevant blood investigations like CBC, ABG, RFT, LFT, and electrolytes, and imaging studies like X-ray and USG. If there are features of sepsis and ileus and history of blood in stool, and X-ray suggestive of pneumatosis intestinalis, then the probable diagnosis is of necrotizing enterocolitis. If history of bilious vomiting is present and X-ray suggestive of more than 3 air fluid levels, then a diagnosis of intestinal obstruction can be made. If there is history of failure to pass meconium and the contrast enema study is suggestive of Hirschsprung disease, then it's safe to proceed further with a rectal biopsy to confirm the diagnosis for Hirschsprung disease. For patients who belong to the age group of more than 2 years and less than 18 years, if there is history of bilious vomiting or bloody diarrhea, and in examination there are findings of fever, abdominal distension, absent bowel sound, rebound tenderness, rigidity, and voluntary guarding, then relevant blood investigations can be carried out and imaging studies can be carried out like USG, X-ray, and CT to look for the diagnosis of either appendicitis or bowel obstruction or perforation, intussusception, malrotation, testicular or ovarian torsion, or volvulus. If the history and examination findings are not suggestive of the above mentioned signs and symptoms, then we can look for the urinary symptoms and carry out urine analysis to look for urinary tract infection. If there is history of bloody diarrhea, then a diagnosis of dysentery or inflammatory bowel disease can be made. If there is no history of bloody diarrhea, then a diagnosis of viral gastroenteritis is made. If there is history of constipation and X-ray and CT are suggestive of so, then the history of constipation or bowel obstruction is made. Now I would like to invite Dr. Muskan Bhutia to carry forward with the OBGYN causes of acute abdomen.
Moving forward with the gynecological causes of acute abdomen, these causes are broadly divided into obstetrical causes and gynecological causes. Obstetrical causes. Physiological causes include round ligament pain in pregnancy. Pathological causes include ectopic pregnancy, abortion, placental abruption, chorioamnionitis, red degeneration of fibroid, and uterine rupture. Gynecological causes. Physiological causes include Mitchell-Merz pain, primary dysmenorrhea. Pathological causes include secondary dysmenorrhea, pelvic inflammatory disease, tubo-ovarian abscess, adnexal torsion, hemorrhagic ovarian cyst, or ovarian hyperstimulation syndrome. Can anybody tell the classical triad with which the ectopic pregnancy presents? Ectopic pregnancy presents with the classical triad of amenorrhea, irregular bleeding, and acute onset of pain. It is usually associated with the symptoms contributing to hemoperitoneum like dizziness and syncope. On per abdomen examination, there is tenderness, guarding and distension. On per vaginal examination, there is tender adnexal mass and cervical motion tenderness can be present. Abortion. Patient presents with the complaint of vaginal bleeding after amenorrhea or positive pregnancy test. Patient also complains of pelvic pain and expulsion of product of conception. There is purulent foul-smelling discharge in case of septic abortion. On per vaginal examination, we should determine the status of the os, the size of the uterus, or if there is any tenderness present. This is an intraoperative image of a 25-year-old female presented with sudden and severe pain along with nausea, tachycardia and apprehension. She was wrongly diagnosed as acute pancreatitis outside at a private hospital. Can you guess the diagnosis? It is a case of adnexal torsion. On per abdominal examination, there was direct and rebound tenderness. On per vaginal examination, there was a large pelvic mass which helped in making the diagnosis.
Again, here we have to remember that the torsion is for a long time.
Yes, sir.
Twisting or removal of torsion could ठीक करने
Untwisting it.
because infarction and ischemia has been so bad that you cannot save you. Okay? Then you have to do for
Oophorectomy.
But if it is the patient has come until you diagnose early, then you can save you.
Yes, sir.
Okay?
Hemorrhagic.
आपने छोड़ दिया उसको टॉर्शन को करेक्ट करके.
Yes, sir.
तो
Oophorepex.
yes,
Oophorepex. Yes. Hemorrhagic ovarian cyst. Patient usually presents with the sudden pelvic pain due to stretching of the ovarian capsule, followed by generalized abdominal pain after hemoperitoneum and associated dizziness and syncope. On per abdominal examination, there is significant tenderness and rebound tenderness. On per vaginal examination, a palpable mass and tenderness in fornices can be present. Acute pelvic inflammatory disease and tubo-ovarian abscess. Patient usually complains of acute pelvic pain along with systemic symptoms like fever. Purulent vaginal discharge can also be present. On per abdominal examination, direct and rebound abdominal tenderness is present. On per vaginal examination, cervical motion and bilateral adnexal tenderness is present in acute PID. Mass in cul-de-sac can be appreciated in tubo-ovarian abscess. Dysmenorrhea. Patient can present with recurrent pelvic pain with menses. There is normal pelvic examination. Approach of acute abdomen in a female of reproductive age group. All women presenting with acute abdomen in reproductive age group should be screened for pregnancy. If a patient comes with the complaint of amenorrhea, after positive pregnancy test, if there is any enlarged uterus on per abdomen per vaginal examination, to USG scan, we can give the diagnosis of abortion. If there is presence of symptoms contributing to hemoperitoneum, after USG scan, we can give the diagnosis of ectopic pregnancy. If patient presents with fever and systemic symptoms, there is adnexal and cervical motion tenderness on per vaginal examination, and after USG scan and supportive investigations like CBC, CRP and vaginal swab, we can give the diagnosis of PID. The patient presents with dysmenorrhea, dyspareunia and adnexal mass. We can give the diagnosis of endometriosis after imaging. If the patient presents with lower abdominal mass, if the mass is uterine in nature, it can be a degenerated myoma. We can give the diagnosis after imaging. And if the mass is adnexal mass, it can be an ovarian or a torsion of ovarian cyst.
Good morning, respected teachers and my dear colleagues. I'll be discussing the role of radiology in acute abdomen. The different modalities used to diagnose a case of acute abdomen include X-rays, ultrasonography, CT, MRI, and others like MRCP, ERCP, or barium studies. The role of abdominal radiographs is that it is a screening modality. It is easily available and quick to perform. Along with AP supine X-ray of abdomen, X-ray chest PA view should also be done in cases of acute abdomen to rule out intrathoracic causes. Although abdominal X-ray have a limited role in recent times, few important indicators are as follows. First is pneumoperitoneum. The most important sign of pneumoperitoneum is gas under the diaphragm, which appears as radiolucency under right dome of diaphragm, forming a crescent as low as 1 ml of gas can be seen on erect X-rays. I would like to ask the audience to spot the second image and give the diagnosis. What is this sign known as? Yes, this is the regular sign, also known as double wall sign. It can be seen when gas is outlining both sides of the bowel, i.e. gas is present inside the lumen and in the peritoneal cavity, allowing good visualization of the bowel wall. It is seen with large amounts of pneumoperitoneum of more than 1000 ml. Another important indication for plain radiography is intestinal obstruction, which can be small and large bowel obstructions. In small bowel obstruction, multiple dilated loops measuring more than 3 cm are predominantly seen in the center of the abdomen with complete valvulae convenientis and may give the coil spring appearance. In large bowel obstruction, dilated bowel loops measuring more than 6 cm are seen at the periphery of the abdomen with incomplete haustral pattern. On X-ray erect abdomen, multiple air fluid levels more than 3 in number and more than 2 cm in height are highly suggestive of intestinal obstruction. The step ladder pattern of air fluid levels from left upper to right lower quadrant is also evident of intestinal obstruction. Another one of the common causes of bowel obstruction is volvulus, which can be detected on abdominal X-rays. In cecal volvulus, there is marked distension of the large bowel loop, with its long axis extending from the right lower quadrant to the epigastrium or the left upper quadrant. The caliber of the cecum should be more than 9 cm with maintained haustral pattern. In sigmoid volvulus, abdominal radiographs will show a large dilated loop of colon with specific signs such as the kidney bean sign, the Freeman-Dahl sign, which is 3 dense lines converging towards the site of the obstruction. There is absence of rectal gas, the liver is overlapped by the sigmoid colon, and a specific sign known as the northern exposure sign, which is on supine X-ray, the apex of the sigmoid colon is present above the transverse colon is seen. In mesenteric ischemia, there is marked edema of the bowel wall, leading to thickening of the haustra at regular intervals, which appears like thumbprints projecting into the aerated lumen, hence giving the name the thumb printing sign. Another important sign is pneumatosis intestinalis, where the gas is present within the bowel loops and its wall. In necrotizing enterocolitis, which is a common cause of ischemia in pediatric age group, the following signs can be seen on abdominal X-ray. Due to intraperitoneal air and ischemia, the bowel wall becomes thin and it appears like a football sign on the lateral X-ray of the neonate. Due to necrosis, the air enters into the bowel and intramural air becomes one of the most important signs. The renal and ureteric calculi are seen on X-ray KUB as radio-opaque densities within the kidney, ureters, bladders, or suggesting of calculi. The radio-opaque stones are usually the calcium stones, which can be visualized on X-ray. Sometimes the cystine stones can also be visualized. And although radiographs have a limited role in inflammatory conditions, but sometimes following signs can be suspicious towards the diagnosis of pancreatitis, like the colon cutoff sign, which is seen in the proximal colon associated with abrupt termination of the gas within the colon, usually at the level of the splenic flexure, and decompression of the distal bowel. This results from the inflammatory process extending from the pancreas to the phrenico-chronic ligament via the transverse mesocolon. The sentinel loop sign can also appear as localized ileus due to the surrounding edema. Role of ultrasonography in acute abdomen. It is the first line investigation. It is easily available. There is no risk of radiation. Dynamic evaluation is possible. However, the limitations are gaseous abdomen, bowel pathologies, and retroperitoneal pathologies. In appendicitis, a dilated, non-compressible, blind-ending aperistaltic loop is seen in the right iliac fossa, giving the target sign, which measures more than 6 cm in diameter with a wall thickness of more than 3 mm and probe tenderness is present. In cholecystitis and cholelithiasis, ultrasonography is the investigation of choice. The gallbladder stones appears as echogenic foci with distal acoustic shadowing in the GB lumen. They may show gravity-dependent movement with change of position known as the rolling stone sign. On color Doppler, twinkling artifacts can be seen. If the GB wall is more than 4 mm in diameter, it is suggestive of cholecystitis. Ultrasonography can be used to differentiate different types of liver abscesses. Like pyogenic abscesses are usually small and multiple in clusters or scattered throughout the liver parenchyma. Amoebic abscess is usually round, hypoechoic with low level internal echoes and incomplete ribbon edema around it. The hydrated abscess should show septated cyst with daughter cyst and echogenic material within the cyst. There can be a floating lily sign which is specific of the hydrated cyst. In acute pyelonephritis, the kidneys appears enlarged with abnormal echogenicity of the renal parenchyma with focal segmental hypoechoic areas due to edema or hyperechoic areas due to the hemorrhage, which are suggestive of inflammation. Now I would like to ask the audience to spot this diagnosis. Yes, this is the target sign and the pseudokidney sign seen in the interception. These signs are specific and appears due to concentric alternating echogenic bands formed by the serosa and submucosa on the either side of the hypoechoic muscularis propria, where the compressed inner bowel loop, that is the interceptum, appears hyperechoic with fat in mesentery, and the edematous outer bowel loop is hypoechoic, which is the intersacipiens. Specific conditions in females include ectopic pregnancy and the ruptured ectopic pregnancies, ovarian torsion, pelvic inflammatory diseases, and ovarian cysts. In ectopic pregnancy on transvaginal ultrasound, we'll find first empty uterine cavity and then adnexal mass giving the tubal ring sign, which is a thick echogenic rim suggestive of a gestational sac in the adnexa. When the ectopic pregnancy ruptures, there is extensive hemoperitoneum and the loss of vascularity in the ovaries or the adnexa. In pelvic inflammatory diseases, multiple presentations can be seen, like the cervix can be bulky with multiple Nabothian cysts suggestive of cervicitis. There can be increased vascularity in the periuterine area suggestive of inflammation. In severe cases, hydrosalpinx can present, giving the cogwheel appearance due to the presence of the fimbriae in the fallopian tubes. In ovarian torsion, the ovaries are bulky with pushing of the follicles at the periphery and twisting of the pedicle. The pedicle on color Doppler gives the whirlpool sign. Usually, the venous supply is initially lost, and then in further case, the arterial supply is also lost. Multiple types of ovarian cysts can be diagnosed on ultrasonography. Now, the role of CT in acute abdomen. It has high accuracy, it confirms the diagnosis, it helps in identification of the site of the pathology, it is quicker than MRI, it has high sensitivity in diagnosing the bowel and retroperitoneal pathologies. CT abdomen for volvulus. The CT is the investigation of choice for volvulus. Sigmoid and cecal volvulus can be differentiated on the basis of absence of haustra in the sigmoid volvulus and the site of the dilated loop. Multiple signs pointing towards the towards volvulus is abnormal dilatation of the involved bowel loop causing closed loop obstruction. Most specific sign of volvulus is the whirl sign. The whirl is composed of spiraled loops of the collapsed cecum or the sigmoid colon with low attenuating fatty mesentery with enhancing engorged vessels which radiate from the twisted bowel. The bird beak sign is also significant of the site of obstruction. The CT findings of mesenteric ischemia are that there is thromboembolism of the vessels which can be seen with hypoattenuation of the bowel wall, pneumatosis intestinalis, there can be pneumatosis portalis also which can be seen in mesenteric ischemia. In pancreatitis, the typical findings is focal or diffuse parenchymal enlargement which changes in the density because of edema. There is indistinct pancreatic margins owing to inflammation. Surrounding retroperitoneal fat stranding can be seen. Other complications like pseudocysts can be seen. And the modified CT severity index can be used for assessing the severity of the disease. Thank you. I would now like to call Dr.
Good morning, everyone. I'll be further acute abdomen. So the most common complaint to us in our OPD or abdomen and associated symptoms. First thing we do is check the vitals of the patient. In most of the cases, such patients will either be in shock or have unstable vitals. So we stabilize the patient by oxygenation of the patient, giving IV fluids, IV analgesics, and IV antibiotics if necessary. once our patient has been stabilized, or if it's already a stable patient, we go for a detailed history and examination of the patient. On the basis of these, we go for relevant and specific investigations. Firstly, laboratory investigations. That could be CBC, LFT, RFT, serum electrolyte, serum amylase, serum lipase. There are certain specific points we should be keeping in mind. That is, if we suspect a chest pathology, we should always prescribe an ECG. And if we have a female patient of a reproductive age group, we should never miss out on prescribing a UPT. To further confirm our diagnosis, we could go for radiological investigations such as X-rays. So, X-rays could be X-ray FPA erect or X-ray chest. On X-ray FPA erect, first thing, perforation peritonitis. We could see gas in perforation peritonitis. Once gas under diaphragm confirmed, we don't need to go for any further investigations. We directly take the patient to the OT after stabilizing the patient. Multiple air fluid levels, that is more than 3, if seen, it gives us an idea about intestinal obstruction. Cecal or sigmoid calculi can also be picked up on X-ray. On chest X-ray, again, perforation peritonitis due to the gas in the diaphragm can be confirmed, and other basal lung pathologies. After X-ray, if the diagnosis is not confirmed, we go for USG abdomen. Enormous information can be gathered through USG abdomen. Appendicitis. We can see a tubular, non-compressible structure which is more than 6 centimeters in length and more than 6 mm in diameter, which confirms the diagnosis of acute appendicitis. Certain hepatobiliary diseases such as cholelithiasis, choledocholithiasis and cholecystitis can be confirmed on the basis of USG. Liver abscess can also be confirmed on the basis of USG. Pancreatitis, though much information isn't provided through a USG, but still gives us a hint on the cause of pain abdomen. Certain obstetric and gynecological causes such as ovarian torsion, ovarian cysts, ectopic pregnancy or ruptured ectopic can be picked up on a USG. PID and hepatitis can also be diagnosed on the basis of a USG. If still we can't conclude our diagnosis, we can go for certain high investigations such as CECT whole abdomen. CECT has already been discussed in details by my colleague. There are certain pathologies which are only confirmed on the basis of CECT. That is mesenteric ischemia, which can be confirmed on the basis of CT angiogram. Appendicitis, if we can't come to a conclusion on the basis of a history, examination or USG, we can always go for a CECT in case of appendicitis, if we suspect appendicitis. Pancreatitis can be confirmed on CECT. Sigmoid or cecal volvulus is confirmed on CECT and intussusception too. Other specialized investigations such as RCP and intussusception can be confirmed on basis of these investigations. In case of CBD stone, impacted stone, MRCP and ERCP could be both diagnostic as well as therapeutic. And in case of gallbladder perforation, we could go for a MRCP which would confirm a diagnosis. This was a generalized overview on how we approach a patient who comes to our ER or OPD with a complaint of pain abdomen. Now I'd like to call upon Dr. Shireesh Gupta, sir, Professor and Unit Head, General Surgery.
Good morning, sir. Today we have a brief discussion about the various causes of the acute abdomen, where are the signs and symptoms, how to diagnose. It is very difficult to cover the whole chapter of acute abdomen even in a conference of 3 days or 5 days. So it's very difficult to cover in 40 minutes. These are just brief glimpses which we have provided to you. I think it is very important that we set together all the departments together, because as sir has rightly pointed, that a surgeon might think only about the surgical causes of acute abdomen, he might not think about the other gynecological causes or the pediatric causes. And that is the beauty of this PGCR, that we are able to discuss among the various departments what could be the various causes of the same sign and symptom. And that is the beauty. And I would like to thank our emeritus chairperson, sir, Dr. V.K. Kapoor, sir, Dr. Soni, sir, and Dr. Jain, sir, to provide us a vast knowledge on these topics and to start this PGCR. Certain points which we must carry home after this PGCR is that a detailed history and clinical examination must in any case of any patient coming to the department, whether acute abdomen or any pathology, because that is going to pinpoint towards the cause of the pathology. Most of these acute abdominal conditions, they are emergencies, they are acute emergencies, they are unstable patients, and they have to be dealt with on an emergency basis. One must always keep gynecological diagnosis in mind when we are dealing with the female patients, especially of the reproductive age group. As has been rightly said again and again, that always keep a ruptured ectopic in mind, because that is a very dire emergency. There are only a few dire emergencies besides trauma which needs a surgical intervention straight away without wasting any time. Age and sex of a patient, many times it will help us in reaching to a diagnosis. Abdomen, it is known to be a Pandora's box. There could be a myriad of causes for acute abdomen. So we must always have a holistic approach towards such patients.